Go for it, Kiara, whenever you're ready.
No, okay, okay. Oh, hello, nice to meet you all. Welcome to this special session. Today, I have the honor to go discuss with Dr. Rabih. So my name is Kiara. I'm a CP Solvers team member since quite 3 years now. So yeah, I'm so excited about this and also so nervous.
Oh my gosh, you're the first person who's ever said my full name on VMR ever, I think. It's great to remember my last name. Thank you, Kiara. I appreciate that very much. Welcome. It's a delight to have you back. I know that you've been near and far CPS. You've been like up close and personal, diving in, and had to step away for a long time and then come back. And it's a delight to have you back here, honestly. For those of you who may not have met Kiara, she was one of the first few IMG people to even join the CP Solvers VMR. And it's a thrill to have you back discussing a case. I can imagine that the nerves are high, but we're really, really excited. I also see a lot of familiar faces in the crowd, none the least Ariel, who was also joining us after a long time. Ariel, how are you?
I'm great. I was just explaining it's been hard to join live with my
Yeah.
class schedules, but I've been listening and it's so nice to see everyone again.
I think you need to tell your story again one more time to the crew, because I think it's just mind-boggling to see that you are here. Tell them why it's mind-boggling, please.
Oh my God, you're too kind. I
No, it's
am a
true.
vet student.
Yep, Ariel is a vet student. She's an expert in the care of everything except human beings, literally everything except human beings, which makes her, I think, by proxy, an expert in also human beings. But yeah, it's so cool to have you here. And also, thank you to Ibrahim, David, Hans, Ambish, and Maria for turning your videos on. It makes it so much more interactive. But a special welcome to our case presenter. Hi, Gabrielle.
Hey, hi everyone.
Welcome to VMR. Tell us a little bit about yourself, please.
Yeah, so I was telling everyone I just graduated from medicine last year, did my internship here in the Philippines. I've been basically a general practitioner for the past year, and I have only been able to attend one, I think, VMR live because of the time difference, but on my overnight shifts and everything, whenever I have downtime, I'd be binging the YouTube.
Amazing. Well, it's so cool to have you here. I'm curious, did you go through the case review committee to get your case, or did you present by yourself?
So my friend Bettina was I had presented on the cases, and we would talk about some of the VMRs once in a while. So
That's
yeah.
amazing. Yeah, Bettina has been a powerful force for folks from the Philippines. It's really cool that that you know her as well. That's awesome. Well, we're very excited to jump into your case. Yeah, without further ado, I think Promise is doing the scribing. Thank you, and Aisha's doing the teaching points. So, Kiara, are you ready to rock and roll? Oh, I think Kiara is frozen. I can update
I'm ready.
her.
I'm so
You're ready. I think your video is freezing. I'm not, maybe it's me. But
maybe I can remove my video.
Okay, that sounds good. No problem.
That helps.
Yeah, I think it's smoother now. Okay.
Really?
All right.
Okay, that's
Yeah, there you
perfect.
go. All right, take it away, my friend.
Okay, so just let me know if I'm talking too fast. So this case is a 62-year-old man who came in for bilateral eye redness with purulent discharge, also bilaterally. 3 days before his consult, he used over-the-counter eye drops to help with the symptoms, but he noticed no improvement. And then he also noticed some painful sores in his mouth. And he had a fever with a Tmax of 39.5 degrees Celsius. So he sought consult at an outpatient clinic, and he was diagnosed with acute gingivitis and bacterial conjunctivitis. and given coamoxiclav and tobramycin dexamethasone eye drops. However, a day prior, he started developing trouble swallowing food. He could not tolerate solid foods, but he could tolerate liquid intake. So that prompted him to consult at the emergency room, where he was subsequently admitted and started on piperacillin tazobactam, ciprofloxacin, sodium hyaluronate eye drops, and a mouthwash of nystatin, prednisone, and diphenhydramine. On his second day of admission, he developed a rash over the chest and back. His other symptoms worsened, and he further developed drooling and dyspnea. So
Oh my
we
God,
can
Gabriel.
stop there first.
Kiara, welcome back to discussing on VMR. I hope you're not regretting it by the
Bad.
intensity of this case.
It is.
Just to help us actually start somewhere, Kiara, because I imagine this is a lot to digest. Let's just start maybe with the chief concern, okay? And I think just to say it out loud, the chief concern that the patient started with is bilateral eye redness and discharge. So if you were just to share your thoughts on that limited amount of data, what came to your mind?
Yeah, perfect. So can you hear me well?
Yeah, now it's really good, Kiara. It's
Okay,
like completely
awesome.
normal. Yeah.
Okay, thank you for letting me just talk about the eye redness. Okay, so first I'm gonna start with the this is a young adult kind of elderly male. He's presenting with eye redness. So if I can think about acute settings, the first thing that comes into my mind, considering that this elderly man could have some comorbidities, I'm worried about some acute glaucoma. So that will be my first thought. Then, but common things are common. So eye redness should, we can also consider conjunctivitis, either viral or bacterial conjunctivitis. Conjunctivitis, so difficult to pronounce. After that, other common things, for example, foreign body or some abrasion in the eye. However, if this is a foreign body or some abrasion, I don't think that will be bilateral. So I will put that like a little bit further on my differential. So other that I could consider would be if there is, if considering the level of complexity in VMR cases would be, for example, if this patient have been developing dry eyes, for example, keratoconjunctivitis, Zika, this will be another presentation for bilateral redness. So far that's what I'm thinking. Of course, if I just join redness and purulent discharge conjunctivitis is top of my differential.
Absolutely superb, Kiara. I think that the approach to eye redness should really mimic the approach to cellulitis. Whenever the eye is red or the skin is red, the question is the same. Is it the top surface, the skin involved in cellulitis, or is it deeper, like necrotizing fasciitis or septic arthritis? And we do the exact same exercise with the eye. And the question with eye redness is it conjunctivitis, the cellulitis equivalent, or does it reflect inflammation deeper in the eye? And the depth of the inflammation is either scleritis, uveitis, acute angle closure glaucoma, and endophthalmitis are some of the things. But as you said, whenever there's discharge, the degree of discharge gives you a sense of the level of the inflammation. And with this amount of discharge, there's almost certainly conjunctival involvement. Very few surface structures produce this amount of discharge. So the question is this conjunctivitis alone, or is this conjunctivitis as part of a visceral or in the eye process? Or is this part of conjunctivitis with corneal involvement, as you said, keratoconjunctivitis? And I think that's where you have to study the company that this eye redness keeps. As soon as it's bilateral and has this degree of purulent discharge, you have to worry. Because when it's bilateral conjunctivitis, it often is viral, and the amount of discharge in viral can be a lot, but certainly not to the degree where it is overtly purulent. So now, in most instances where you're like, okay, there's eye redness, it could be anything at the surface or deeper. The more discharge there is, the more it is actually a surface issue. But in this case, the fact that it's bilateral and the fact that it is involved as part of a systemic syndrome makes you wonder if actually it's either a really bad conjunctivitis, like bacterial conjunctivitis, or it's actually more serious than just regular conjunctivitis. So I think that the company that this eye redness is keeping makes us go beyond regular old infectious conjunctivitis and think about more sinister stuff, though it is possible that this patient just has a very bad version of viral conjunctivitis from a systemic viral syndrome. But so I think that we need the eye exam, to help us localize where in the ocular structures this is involved. Still open to uveitis, scleritis, endophthalmitis, or corneal involvement. But if this is conjunctivitis alone, it would have to be a very, very severe form of conjunctivitis. But maybe let's talk about it separately. What do you think about the patient's gingivitis and the dysphagia, the patients having gum issues and trouble swallowing? What did that do for you?
So if it were just eye redness, I would think that's something localized. But whenever I see something elsewhere in the body, I think that this could be related to some systemic disease. So either infectious disease or either some immunologic or rheumatologic disease. So anything that could be affecting or causing gingivitis could be bacterial. Actually, I'm a little lost right now. My differential will be right now bacterial, autoimmune, and rheumatology, which is related to autoimmune.
I completely agree with you. I think you cannot have a differential diagnosis right now. If you do have a differential diagnosis, you're making a mistake. And the reason you can't is you don't know what the problem is yet. And I think we know that the patient's eyes are involved. We know that the patient's throat is involved. And we know that the patient's skin is involved. And there's a component of dyspnea, which remains poorly clarified. And I think the only progress you can make is to clarify each of these things and put them into specific buckets. Like this is ulcerative pharyngitis, or this is keratoconjunctivitis, or this is pulmonary edema or focal pulmonary infiltrate. But I'll just share two reflex things that are going to be really, really important. The first is that this patient's medications are going to be critical. And the reason to think about medications is we're thinking about inflammation, infection, malignancy, autoimmune, and drugs. And the ones that begin abruptly are infections and drugs. And I think here you have to wonder, could this person have SJST and spectrum disease with corneal involvement, pharyngeal involvement, and a rash? So I think the only thing that may not flow naturally that we have to dig deep is a thorough medication review. Did this patient recently have a UTI and get Bactrim, or cellulitis and get something else? That's going to be crucial. But I agree with you. I'm very much in problem-solving mode right now, and I'm really curious to see what the eyes turn out to be, what the throat turns out to be, what the rash turns out to be, and what the dyspnea is. But we really have to worry tremendously about this patient. Alrighty, Gabrielle or Gabby, tell us more, please.
Yeah, well, in fact, the airway was like a major concern when they first admitted this patient. That at one of the first exams they did was actually a flexible endoscopy, just to check the airway right away, which I can mention later when we talk about the exam. You want to start with the past medical history, I think, right?
Please, yeah, whatever you
Yes.
had planned.
Yeah. So this patient had been on potassium citrate for bilateral kidney stones. He's a known hypertensive managed on losartan. He had bronchial asthma managed on a budesonide inhaler, but the patient admitted to not being very compliant with the inhaler, forgetting to puff maybe twice a week. 2 weeks ago, the patient was newly diagnosed with type 2 diabetes and started on metformin. And at the same time, he was found to have uricemia, and was subsequently started on allopurinol. But he stopped the allopurinol on his own because about 3 or 4 days ago, he started feeling an itch. The patient has no known history of food or drug allergies. The family history was unremarkable, and he has no illicit drug use history, no smoking or alcohol or frequent alcohol intake. I can move to the physical exam, or if you'd like to discuss that past medical history first.
Well, I think you set us up really well to have a nice conversation about this stuff. So, Kiara, what are your reflex thoughts here?
Oh, so far he has many important issues. So his past medical history is important for nephrolithiasis bilateral. He has diabetes, recently diagnosed. So whenever I know about someone recently diagnosed with diabetes, my two thoughts are either he was like non-aware about his disease that has been developing for a very long time, or there is some issue with his pancreas that has recently developed. So every time I hear a recent diagnosis in an elderly with diabetes, I'm thinking about some pancreatic either immunologic or cancer disease. He also has hyperuricemia, which also concerns me. Well, it could be related to his nephrolithiasis. So actually, I don't know how to go further right now. I need some help.
100%. I think that this case is very, very complicated, and I think we'll need to make a lot of progress on the exam to help localize these lesions. And I think that it's very, very telling that a lot of stuff has happened for this patient in the recent past. And the question will be, can we connect this syndrome with any recent diagnoses or any recent interventions? And I think that's the kind of thinking to have your problem, and you have it happening in a context. A lot has been happening for this patient. And I think we both have to wonder, is this related to a recent DX? Or despite our logo and our love for diagnosis, we also have to humbly recognize that this also could be related to a recent RX or treatment. So Kiara, if you direct your attention, I'll say them out loud. Can you think of a way that either potassium, budesonide, metformin, or allopurinol can be related to what's going on now?
If I can guess, would be the allopurinol, which has been stopped. So I was thinking about some hypersensitivity reaction with him. Probably even, yeah, so either being even the allopurinol causing, for example, some mediated immunosensitive reaction causing this fever, rash, or I was also thinking about the recent antibiotics he had received. Also, I was thinking about some drug-induced, for example, as drug-induced lupus in this case. So these were the two things I was thinking about.
Yeah, Kiara, I think you should retire now. I think you're on the right track. At least I think so. But that was absolutely amazing. All of us probably have some momentum to some thoughts about specific things, but I think actually none of them matter right now. There's only one thing that matters right now, in my opinion, which is that you're talking to this patient and you probably are laying eyes on them at the same time, and you're getting a sense that they've been devastated by this disease at the surface of their body, their eyes, their mouth, and now we're learning their skin. And I think the key question will be for any rash is to both, or any surface issue, is to understand two big categories. First, what is the extent of the devastation on the surface of the body? How wide is it? Meaning how much of the body surface is involved? How deep is it? Is this rash ulcerative or nodular? And then also the third dimension, how wide, how deep, and then how much it evolves over time will be very informative. But also what the visceral signature of this disease, because if we end up saying that this is a devastating disease limited to the surface, that's a very different diagnostic landscape than a severe disease involving multiple internal organs like the liver and the kidney and the heart and the lungs versus a disease just centered on the surface. Very different differential diagnosis. And if we take Chiara's hypothesis of thinking, could the allopurinol be involved? The allopurinol can be related in two ways. It can be related to its risk of causing drug-induced hypersensitivity syndrome, which is a systemic disease with skin manifestations, or it can be linked with SJS-TEN, which is almost exclusively restricted to the surface of the body and the mucosal surfaces. And I'll ask you, if you're thinking about this case, to try to then say, okay, what does it mean about the shortness of breath? And does the shortness of breath fundamentally mean that the patient has visceral involvement? Or could it be somehow related to a complication of the surface diseases we just talked about? And that's an interesting thought experiment to do. I'll share with you my thinking about it later, but I think it's a good mental exercise to say, does the dyspnea actually confirm that we're not dealing with a surface issue alone? And if you think that the answer is yes, great, we'll see more. If you think the answer is no, then it's a good exercise to ask yourself, how can dyspnea be a manifestation of a surface issue like SJS-TEN? It's a good mental exercise. Even if it's not the case in this case, I'll just share some ways that it can happen even without deep visceral involvement. But I don't want to take the fun of the actual active thinking on your end. So we'll pass the mic to Gabby now to tell us more.
Okay. So moving to the physical exam. So just to contextualize, the exam I'm about to relay was already when the inpatient referral was already done. So this is a couple days after the ER and everything that happened. So the patient's blood pressure was 120/70, heart rate 85, respiratory rate 23. Temperature was 37.8 degrees Celsius and an O2 sat of 93%. So generally, the patient was in moderate to severe distress. The patient was unable to speak, although he relayed that it was mostly because of the pain of speaking, and we would communicate by asking him questions and he would just nod yes or no. So we found though that he was alert and oriented to time, place, and person. Moving to his eyes, his eyelashes in both eyes were there's a lot of purulent discharge and they were very, very matted, almost matted shut. And he really wanted us to refrain from opening it. So we couldn't completely assess the erythema, although the notes we had from previous days indicated involvement of the conjunctiva mostly.
Gabby, can I just ask?
Cardiovascular.
Sorry, I'm so sorry to interrupt.
Sure, go ahead.
Because I think it's a great point for people to. Can you just share with us why he was reluctant? Is it because it hurt a lot, or the light bothered him?
It was at the time it was more because of the pain. So we also there was also no description from him, like when his eyes could still be opened. He didn't note any blurring of vision per se. It was just at the point we saw him, he didn't want to be opening the eyes. Yeah. Okay. So cardiovascular, normal rate, regular rhythm, we didn't hear any murmurs. Pulmonary, we found wheezing across all his lung fields. His abdomen was soft, non-tender, and non-distended. His extremities were warm with full and equal pulses without edema. So for the skin, unfortunately, for patient privacy, we can't show the pictures, but I'll try to describe it as vividly as I can. So this rash, which developed on the second day of admission, it was clustered erythematous circular lesions. Some of them, you could almost say maybe even purpuric over most of the upper back and starting to be very splotchy on the chest. Then there were also scattered erythematous to crusted lesions on the forehead, glabella, and perioral area. The buccal mucosa itself was very erythematous, patchy, splotchy, with some aphthous ulcers, even all the way to the back of the throat. And then he had a 2x2 cm over the scrotum. So a 2x2 cm like ulcer, which was almost weeping over the scrotum. So I think that's a lot to dissect
Yeah,
first.
very outstanding exam, Gabriel. Thank you. I think you really captured the findings without the pictures in such great detail. Thank you so much. Kiara, what do you think?
Every aliquot is a pain for me. So okay, I will keep my diagnosis of this hypersensitive reaction. Like right now, I was thinking his vitals are. I'm concerned of his respiratory rate is elevated. His OSAT is low. So if we were thinking about some involvement, some organ or systemic involvement, I was thinking that this patient will be developing either pneumonitis or some organ involvement consisted with this. So I mean, every time I think about a drug-induced hypersensitivity syndrome, the component which how it manifests should be like pleural component, for example, pericarditis or pleuritis, or in this case, pneumonitis, which is what I'm thinking about. I'm not that good with dermatologic skin rash differential, but the only fact that he has a skin rash make me think about this concern. I actually don't know much what to do with this. Still thinking about this issue.
It's very, very complicated, Kiara. I think if you think about it, you're dealing with a critically ill person who probably has many consultants on board. So having any degree of confidence at this point is probably premature. And I think all you really can do is just try to track this problem and understand this problem. You haven't formed an equation yet to try to solve. You're just trying to figure out, okay, what is the issue here? And I think that you're underselling your understanding of the skin. All you have to do is just be impressed by how bad it is. That's it. This is not just some tinea pedis or a fungal infection. This is a devastating rash everywhere that has evidence of deep involvement. And what are the evidence that it's deep? There's purpuric appearance to it, and there's a 2-centimeter ulcer over the scrotum, right? That's an ulceration. So this is basically a really bad skin rash. And that's all you need. And then the next question is it a really bad skin process with a visceral accompaniment? Or is it a really bad skin process that's restricted to the skin? That's it. And then after you determine that, it becomes very, very simple. If it's a superficial process, if it's a really bad process limited to the skin, it's all about the drugs. There are very few conditions that cause devastation in the skin alone, disproportionately dominating the skin, and it's all about drugs. There are some other things to think about. 1 or 2 infections, namely disseminated HSV and disseminated VZV, can do this. In terms of bacterial infections, there's also a couple, Mycoplasma is notorious for causing severe ulcerations. The term for that is there's I think it's MIRM. I forget what it stands for, but mycoplasma induced mucosal disease, something like that. And then toxin-mediated disease by staph, usually Staphylococcus aureus, but also by strep. So if you have a short list of infections that devastate the skin alone, it's only those. But I said that prematurely. I shouldn't say that now. The next step is this a systemic disease with surface manifestations, or is this a disease restricted to the surface? Very different landscape. But I will tell you, actually, let me just see. Chiara, what's your instinct? Just for practice, really. Do you think that the labs are going to say this is a systemic disease with skin manifestation, or is your instinct that the labs will be relatively normal compared to the skin? What is your feeling?
Yeah, for sure, CBC will have probably altered WBC, probably some kind of thrombocytopenia or thrombocytosis, which can manifest some systemic or like very important inflammatory process. Then I'm probably guessing that the liver panel will be also alterated. So yeah, labs will be alterated, pointing into a very inflammatory disease.
I love it. Okay, Chiara, I love it. And I'm curious, how surprised will you be if the labs are stone cold normal?
Yeah, we'll be very surprised, but
Yeah.
nothing is that interesting, right?
Yeah, it'll be very, very interesting. And I think VMR is all about being surprised, and VMR is all about learning small nuances that help you learn and grow. I'm curious if for those of you who are have the ability to make this a richer conversation and put our heads in, please put in the chat your guess and keep it simple. Labs positive or labs negative? Just what you think. And the more people we have to participate, the more it can be engaging and the more we'll learn from this case. So far it's exactly 50-50, 2-2. Now labs negative are leading. Now it's 4-4. All right, keep it coming. Labs negative, labs negative, labs negative. Maria's emphatic positive. I think Maria gets like 6 votes for that. Okay. Chiara, it's very, very close. I'll share my thoughts. I think the labs are going to be completely normal. And the reason for that is a fun thing that we can reflect on at the end. SJS-TEN typically causes devastating skin lesions and mucosal involvement with little to no visceral disease. In stark contrast, drug-induced hypersensitivity syndrome can cause really bad visceral disease, but the rash is usually not this ulcerative. So just based on the data alone here, that the fact that there's mucosal involvement and the fact that the ulcerations are present suggests more SJS-TEN spectrum than DRESS or drug-induced hypersensitivity spectrum, which usually features a rash, but the rash is not commonly ulcerative, and the rash commonly does not involve the eyes and the oral mucosa. So it is fascinating to see how SJS-TEN can destroy the skin without making a visceral imprint. But what is the visceral imprint we have here? We have dyspnea, hypoxia, and wheezing. And that's where you have to remember that the airways of the lungs are actually an extension of the mucosal surface. And you can get SJS-TEN involve the airways, causing airway stenosis, constriction, and even going down all the way into lower airways, causing bronchiolitis. So we'll see what the labs show. I think you can't be confident enough about the labs to not get them. So let's be real. We still need them. Otherwise, we would know. But my sense is they're going to be negative. Either way, we're going to learn a lot and enjoy the rest of the data that Gabby has for us.
All right, so we'll start with the CBC. So the main finding that we had was an elevated white blood cell count, so at 12.4, with a neutrophil predominance at 76%, but we also had lymphocytes at 15%. The rest of the CBC is generally unremarkable. BUN, CREA, electrolytes were normal. The ALT was still within the normal range. AST was at 63. For our lab, our upper range was 59. So AST is slightly elevated. Blood cultures and oral swab for microbiology were taken. They came back negative. The chest x-ray was unremarkable. And the flexible laryngoscopy showed the erosions in the oral cavity that I just described. But the only other remarkable finding was some inflammation of the epiglottis, but no evident obstruction.
Absolutely amazing. Kiara, what do you think?
Well, it was kind of alterated, but it wasn't that remarkable. So I don't know where I stand right now. So oh gosh. So still pointing out of some kind of severe inflammation, either rest could be also SESDN. I also was thinking every time, maybe I'm biased with that, but every time I see high lymphocyte elevation of lymphocytes, I'm thinking about some acute viral infection. So that will be a reason why some cultures can be negative. And so far, that's what I'm thinking.
Yeah, I agree with you. I think that the labs are, if you're strictly speaking, the labs are positive, but if you're weighing them in proportion to the degree of skin involvement compared to the degree of laboratory involvement, I think they're relatively underwhelming and not as impressive. But strictly speaking, this person has a rash, has lymphocytosis, and has liver enzyme elevations. And so you have to start to think, okay, is this drug-induced hypersensitivity syndrome? And at the end of the day, I would say that the overwhelming data is now suggesting that this is a skin disease with very little visceral imprint. But the visceral imprint is notable. So I think the next steps really are asking, well, what other things do we need to exclude apart from drugs? And I think that that's when you probably have a decision to do about HSV testing as a consideration, mycoplasma testing, and then whether or not you would image the viscera to see if this is a perineoplastic process. But I think in most instances, the threshold for empiric treatment for a drug reaction has been crossed. That's what I would think. So I think regardless of your diagnostic interventions, I think now is the time to initiate empiric therapy. And just to acknowledge it, there is a spectrum of overlap between SJS-TEN and drug-induced hypersensitivity syndrome. So in most cases, patients have a clean SJS-TEN versus drug-induced hypersensitivity syndrome. And for clarity, the classic presentation of SJS-TEN is a high fever, like this patient has, mucosal involvement first, like this patient had, followed by skin involvement. And the mucosal involvement is devastating, ulcerative, and severe. The classic presentation of drug-induced hypersensitivity syndrome is a visceral disease of renal and hepatic predominance, followed by, or in sync with, an erythrodermic rash. This patient is 90% TEN, but the lymphocytes and the mild AST elevations suggest some features of drug-induced hypersensitivity syndrome. Why is it important for diagnostic precision? The treatments of SJS-TEN and drug-induced hypersensitivity syndrome are slightly different, and the long-term prognosis and the complications are different. With drug-induced hypersensitivity syndrome being the most important long-term complication is the delayed presentation of cardiomyopathy or heart failure, and the delayed presentation of thyroid disease. So that's the reason why we try our best to get diagnostic clarity. And I think a skin biopsy would probably help push us one way or the other. Did you have any other thoughts, Kiara, before we hear back from Gabby?
Well, actually, that explanation about the differences on presentation of both is really helpful, and sure it could be an overlap. And I was thinking about the treatment. If it would be dressed, the initial measure will be take off the potential medications, and well, he already stopped allopurinol, so we can assess some other medication he can be taking. Also, steroids could be could be the could be the next treatment for this is if this is the case, but I don't know. I don't know. I for sure if I'm seeing this patient right now, I will be concerned of his acute disease, and I will be treating the symptoms and the acute management either if before trying to diagnose for sure.
Yeah, 100%. I completely agree with you. The threshold for empiric treatment has definitely been crossed. I completely agree with you. Alrighty, Gabby, tell us more, please.
Okay, so this is kind of the last aliquot I have, because at this point, as everyone's been saying, we've crossed the point where we really do need to intervene here to change the course of the disease. And that was the thinking of my attending at the time. So the attending decided to do more of like a test of cure, try an intervention and see if it works within 48 to 72 hours. Because our clinical diagnosis at this point, at least in in my country, did not have or does not have a CPG or clinical guidance, and we had to go to defer to whatever research was out there. So this patient was given IV methylprednisone at very high doses, and we actually saw magical, almost immediate improvement in 48 hours. The patient went from being unable to speak to be able to carry a conversation despite a slightly with some slight difficulty. So based on that patient's reaction, the final diagnosis was as a case of SJS due to allopurinol with secondary bacterial infection.
Yeah, you presented this like a pro, really, even just the delivery at the end, but yeah, I think that the decision, I was actually really curious why you were giving us so much information in your first aliquot, but it became fundamentally clear that you were painting a very excellent presentation of a mucocutaneous disease, allowed us to reflect on it, and then boom, came in with the key clue of the medications right after. And that really set us up for a great conversation. So really, really appreciate you doing that. Kiara, how did it feel for you?
I'm so happy I could discuss with you because I for sure need your help. This was a very complex case and a very interesting one. It's sometimes when there is some overlapping between symptoms, it's hard to differentiate. But as I previously mentioned, I was very worried about this patient, so I'm glad after this empiric steroids, he improves his symptoms and overall his condition. So I learned a ton as always, and I'm surprised as always after every VMR.
I know, really, really grateful to you for jumping in and discussing a very complicated derm case. I think people talk a lot about the neurophobia, but with Aaron, Maria, Vale, and Gabby's efforts, I think neurophobia has become dimmer and dimmer, but derm phobia remains very, very prominent. And so hopefully this case, I think, reminds us of a very simplistic approach, which is just figure out how bad it is on the skin, figure out how bad it is on the inside, and that should really take you the vast majority. And I think we had a great example of that in our Monday subspecialty VMR when a patient had nodules everywhere, a high LDH, a high lactate. That was a bad skin disease with visceral involvement. And it turned out to be I don't want to spoil it, but it turned out to be a systemic process going to the skin. But this is the exact opposite. This is a skin predominant process. And I think now you can update your illness scripts to be like, if the skin is utterly devastated in an ulcerative mucocutaneous way, the viscera is probably not going to be affected to a high degree. But I think I'm most intrigued, Gabrielle, by two things. One, what it was like to take care of this patient, and two, what lessons you learned kind of operating in a space where you didn't have as many resources as I think you would have liked to, as you alluded to at the end. So please enlighten us on those two things if you can.
Yeah, so this was a case from my clinical internship. So as an intern at the time, I was just very lucky that we were assigned to the particular attending at the time of the referral. So we really saw exactly what the attending or the residents were seeing and figuring it out. So it was kind of mind-blowing, and the moment that we heard in the history allopurinol, and it was like, it smells like SJS, it looks like SJS. It's so rare to see whatever you read in the textbook actually like appeared before your eyes. And it was even more more, I guess, wild and more of a kind of taste of the real world when we looked at how are we gonna treat this patient. Because the way our attending handled this was she wrote her notes and said, this is how we're going to treat the patient, but she gave us the two options, and of like how SJS is treated, like the two contrasting schools of thought, which was, at least at the time, high dose really fast courses of steroids, or low dose very long courses of steroids. And we had to meet her after, discuss the case, and show our research, come to our own conclusions. So this particular patient was like an amazing exercise for us, like as med students at the time. So I guess with practicing medicine in a resource, in a like a setting where you don't have all the tools, because in preparing for this case, I think Curtin was talking about how I think in the US they already have genetic testing for if you're gonna give allopurinol for in certain subgroups. So we didn't have access to those kind of things. It just emphasized how much looking at the clinical signs and eliminating like what will kill the patient the fastest as your kind of your MO in going down the line was like such a useful tool. And I mean, the patient almost completely recovering in like 72 hours was just like amazing proof of that.
Yeah, I couldn't agree more. I think that was so well said. And yeah, you're right. I think there are more and more resources out there, but there's always inequity in their access. And I think slowly but surely, hopefully that is resolved and is mitigated. But yes, there's a test called HLA-B5801, which helps predict the risk of hypersensitivity to allopurinol. And that HLA-B5801 has variable penetrance across different populations, and is especially penetrant in some subpopulations in in East Asia and Southeast Asia. Very, very educational. Thank you so much, Gabrielle. We hope that you continue to join us live as much as you can, and that we learn with you and from you. It's been a real treat today. But thankfully, we get to go through the journey one more time. Aisha, take it away.
Hi everyone. Thank you so much for that case, Gabriel. Cases like these make me grateful for being part of CP Solvers. An amazing discussion, everyone. Okay. So teaching points for today, we started off with a 62-year-old male with bilateral eye redness and purulent discharge. So when we have eye redness, we want to figure out, when we have eye redness, we have to figure out if it's just cutaneous skin involvement, or is there a deeper issue? This kind of idea kind of rolls throughout our case. We were trying to figure out if it's just skin involvement or a deeper visceral issue. And the degree of discharge in the eyes can determine the level of inflammation present. And for this patient, there was bilateral discharge, which could possibly clue us to a viral etiology. And the more discharge there is, normally, the more likely that it's going to be a deeper surface issue. And a lot of the causes, such as infections, drugs, inflammatory, for this specific patient who had subacute symptoms in the course of 3 to 4 days, we would be prioritizing infections and drugs as some of the causes, as we found out. And when there's a rash, we want to figure out the extent of the devastation of the rash on the surface body. So what that means is, how deep is the rash, or how much of the body does it cover? So how wide is it, and how much has it involved in a certain time period? And when we found out that this patient is taking allopurinol, that kind of gave us a hint. It could be a hypersensitivity reaction. It could be because of this specific drug, even though it was stopped 3 to 4 days ago. And when we're thinking about superficial and deeper diseases, both of those are going to give us very different diagnoses. And this patient also had dyspnea, so that makes us think, is this going to be more of a deeper issue? Could possibly be a deeper issue because of the dyspnea, but that's just one of the findings. We don't want to overlook all the other cutaneous findings. And when there's a superficial rash, we want to think mostly about drugs. So most of the time it's going to be drugs. And when we have this rash, we want to think if it's a systemic disease, and which is a part of a derm manifestation, or is it just a superficial rash? And after we found out the physical exam and some of the labs, we were thinking it could be SGS or TEN. SGS and TEN, both of those cause more skin lesions and mucosal lesions rather than visceral lesions. So in this specific scenario, the labs could potentially be negative because the disease involvement does not include visceral majority of the time. And the airway stenosis and bronchiolitis could also clue us to thinking that it could be mucosal involvement, because that could help us think of mucosal involvement. That could help us think of a mucosal involvement. And when there's SGS or TEN, usually patients present with a high fever, mucosal involvement first, which is followed by skin involvement. And the mucosal involvement is usually devastating, it's severe, it's ulcerative. And then we were also thinking about drug-induced hypersensitivity syndrome. That one, in comparison to SGS, actually has more visceral involvement. And it starts off with visceral involvement, renal and hepatic predominance, with a erythrodermic rash as well. And a delayed presentation of SGS or drug-induced hypersensitivity can have complications such as cardiomyopathy or thyroid disease. And in this patient, our final diagnosis was SGS due to allopurinol. And in some countries, there is a test called HLA-B51 that can help to determine the hypersensitivity to allopurinol. Thank you so much for listening.
Awesome. I feel like we're hearing you teach left, right, and center, Aisha, on Tuesday and here again today. Thank you so much for jumping in and recapping so much wisdom on VMR. Much appreciated. All right, Gabriel, hope to see you. Good luck with the rest of your, well, actually, what are you doing next year? Do you know? I have to ask earlier.
No, I don't know yet.
You're still figuring out, huh?
Yeah.
Amazing. Well, best of luck to you. We hope to see and get to know more of you. And thank you again, Kiara, for discussing in the heat. Your picture is ice cream, I think, and I think it's very, very, very telling.
Yes, thank you so much for this opportunity. I missed you all.
Well, best of luck with your rotation, and hopefully we get to see more of you when you're back in Peru.
Yeah, of course. I would love to. Thank you.
All right, bye, guys. Bye.
Bye. Thanks, everyone.